Good morning. Thank you to Sposi and Madam President for giving me this opportunity. So, I'm talking about something when we see children like this in our clinic. uh, when we see children like this, or this, we are really not thinking about atropine in these children or DIMS in these children. We are also looking at what is causing so much of high myopia in these. So, it's a high myopia is also pathological or high myopia is also going to be an impending epidemic, and prevalence is expected to be 0.5 to 3, which makes it at least a few million people if you look at world over. It is going to be much higher in Asians. How do you define high myopia or pathological myopia? Any myopia which is more than 6 diopters, increased axial length that is at least more than 26 millimeters, which presents early in childhood, progressive, and most important, what defines from a high myopia from a pathological myopia, that there should be some amount of pathological changes at the level of macula and retina. So, what causes these? What is the reason for this? Is basically it's excessive axial length elongation, which produces a biomechanical stretch on the posterior pole, leading to which in turn leads to staphyloма and optic disc changes. You have a tilted optic disc. You can have lacquer cracks or myopic macular degeneration, and often uncorrectable visual loss. So this is what a typical pathological myopia looks like. This is not just high myopia. This is not just minus 13, because visual acuity is less, and you can already see macular changes as well as a tilted optic disc, myopic disc in this. So what does workup entail in these patients? You have to look for visual acuity, refraction, pupils, intraocular pressure, careful fundus examination with special attention to macula and optic nerve, and occasionally you may need imaging and OCT. So this is a older classification of pathological myopia, and they use it, but it does not include the OCT or newer imaging techniques. So nowadays this has been modified. I've used it for easier understanding. So what is the management in pathological myopia? Contact lenses work better than glasses, and you should probably push for contact lenses than glasses in these children. A careful follow-up is required because some of them will have progressive myopic macular changes, and it's ideal to probably have a retinal imaging for comparison during follow-up, and you may need additional interventions for maculopathy and degeneration if it progresses further. What is syndromic myopia? On the other hand, syndromic myopia is actually myopia associated with ocular and systemic disorders. It is monogenic with a wide spectrum of clinical presentations. Why approach is different?
थोड़ा माइक पास ले लो.
Why approach is different in pathologic myopia versus syndromic myopia? Because these are younger children. There is a real risk of visual impairment, and myopia may be just the tip of the iceberg, and there is a possibility of genetic transmission in these. So workup in these children involves a little bit more history, a more careful visual acuity, intraocular pressure, and a detailed fundus evaluation. In addition to just these, which is part of any comprehensive ophthalmic examination, you may also need to do imaging, electrophysiology, OCT, and genetic testing depending on what you see. So these are the common syndromes which are associated with myopia. Children may present only with myopia, but you have to look at all these things, especially if you see a very high myopia, visual impairment, and relatively normal looking fundus. So what are the red flags to pick up syndromic myopia? Family history, birth history, history of consanguinity, history of first degree relatives with visual impairment, younger children with high myopia, for visual acuity which is not improving despite wearing glasses and patching, presence of nystagmus, which unless you look for it sometimes easy to miss, poor color vision, dysmorphic features, and altered fundus background, and more before anything else appears, arterial attenuation is the only thing which sometimes can be seen if when the child presents to you at the age of 3 years or 4 years. So if you look at this picture, this is a 13-year-old, came with nearly normal looking eye on examination, but if you do autofluorescence, you can see definitely there is problem in the macula. And again, the red flag here was a visual acuity with moderate myopia. She should see 6 by 6. Why is she only 6 by 18? That's what should give you the pointer here. And of course, when you do examinations, color vision was poor. If you actually look at her ERG was normal. Full-field ERG was normal because it's just a macular pathology there. But if you do a multifocal ERG, you can see depressed macular region, and of course OCT when she was a little older than what she first presented with, we did OCT and that showed foveal thinning. And of course we did a genetic testing in her and mutation was seen in CNGB3, which is associated with achromatopsia. Her father also had a mutation in the same region. She was counseled and no vision devices were prescribed. Another patient 2, this is a 10-year-old, history of poor vision. Again, visual acuity is 618, has been wearing glasses, -8 with 618, doesn't correlate. This is not amblyopia, this is something else going on. So on cover test, she has exotropia. But in the fundus evaluation, when you see a dilated fundus evaluation, you can see a temporal avascular area with multiple lattices in both the eyes. There is a avascular wedge which is extending right up to the fovea in the right eye. So there is if you see picture here, there is there a pointer? Pointer? No. Cursor. My cursor is not showing up here. So you can see temporally there is a kind of a fibrous wedge.
He has pointer.
Okay.
He carries his pointer all the time.
Thank you so much. Because this projection is not too great. So you can see here, that is a fibrous wedge which is coming right up to avascular area. Retina is, you can see there are no vessels there. And more easily visible in the left eye, you can see a temporal avascular area. And sometimes when they are not dilating poorly, they are not looking at where you want them to look. These are things which are easier to miss, and that's where sometimes photography is probably useful. So here the diagnosis was either FEVR because of this avascular area with the fibrous edge, or a regressed ROP, but she didn't have any history of ROP. Now more history was taken. Father has poor vision in one eye. History of retinal detachment surgery. Father was also examined, and that is her father. So you know this is not regressed ROP, and this probably is FEVR, which is, you can see similar fundus picture in the father also. So yes, she was given glasses and need for close follow-up was explained because she had multiple lattices. She needs more periodic examination, but that's how sometimes it helps you to come with the diagnosis. Again, another patient. This patient has dysmorphic features. Both eyes CSM, -21, -23, anterior segment normal. Posterior pole looks okay. However, when we do optos, it shows multiple lattices. There is, again, more history of detachment in father and brother. Brother also has had a cleft-lipped surgery. And yes, when we do a genetic testing, there is mutation. This is the mother in COL2A1, and probably they have sticklers because of multiple lattices, dysmorphic features, cleft lip. All these are associations with sticklers. This is, I think, brother. Again, another patient, 8-year-old, poor vision, nystagmus, delayed milestones, cyst in the occipital region. If you look at the anterior segment, one eye has total cataract, other eye has non-dilating pupil with small, but we were able to take optos. On optos, it looks like retina is attached, but when we do an ultrasound, it shows retinal detachment in both eyes. Right eye, of course, had no view, but left eye, where what we could see was only this much here. So this looks maybe pale disc, but nothing else. On ultrasound, there was some retinal detachment in both the eyes, and optos does confirm retinal detachment in the periphery. We look at the brother who is visually impaired, occipital encephalocele in him also, right eye hand movements, left eye no PL, nystagmus, anterior segment both eyes cataract, and ultrasound shows total retinal detachment in both the eyes. Genetic testing was done and mutation in COL18A suggestive of no block syndrome. So sometimes family history is important, and you need to probably look at more than just patient, but also family members as well as more detailed history. So how do we help these children? You should give optical correction, glasses or contact lenses. You should not, vision is improving to -18, 3/60, I will not give glasses. That's not the right approach to do it. You should give -18. Diagnostic imaging is required whenever it is indicated, close monitoring and follow-up. interventions in terms of laser, cataract surgery, retinal surgeries is all required during the course of follow-up. Several of them will have progressive visual impairment despite your best efforts. So low vision services may be required. You may need to help them by giving them appropriate certifications of disability and facilitating their access to services and whatever little benefits governments offer. Genetic testing and counseling, of course, they are young children. Parents may want to have another child. They may need to know what's happening. You need to offer them these services, or at least refer them to a center where it can be done. Cataract may be a presenting feature, and surgery can be challenging in terms of dilatation, deep set eyes, etc., etc. Strabismus surgery may be required because both ESO and exotropia are seen. I am talking in terms of more interventions which may be required just along with glasses. So imaging of muscle helps in the surgical plan, as displacement of the muscle may not respond to traditional surgical plans. Important to measure with contact lenses because their angles are different because of high myopia, and you should always be aware of a very thin sclera in these patients. Thank you for your attention.
Just one question these eye myopes, sometimes it is difficult to do an OCT.
Yes.
Sometimes I feel
because
like
of
seeing
nystagmus.
how is the macula, but then it doesn't come, the picture.
Yeah, at some point you will get it, but as I said, your OCT decision is not going to change your management majorly.
Yes.
Maybe counseling may change a bit, but it is not. So till you get a good picture, there's no harm in continuing with whatever you need to know to preserve the vision, to follow up, to make sure that you're not missing out on any lattices and any other dangerous lesions which need to be treated.
So
and
clinically, how would you nail that these are pathological and not just the simple myopia which is beyond -6?
As I mentioned, those red flags, visual acuity not improving, definitely a red flag, despite wearing glasses. Sometimes very abnormally high myopia, and as I said, family history is important. Some of it is not volunteered, mind you. They will not tell another brother who is not unless you ask for it. So family history of first degree relatives having poor visual outcome, poor in vision, is a very, very important red flag, and a lot of this history is not volunteered unless you ask for it. So you have to, and arterial attenuation. But a simple pathological myopia which is not going to lead very bad visual impairment or other syndromes, you will probably see the macular changes. There is a macular thinning and all, which is clinically very obvious. Yes, you can confirm it with OCT, but you will get OCT picture at some point in their follow-up.
Thank you, Dr. Sumita, for a nice presentation.